And it's my pleasure to next introduce Dr. Lourdes Karopoma. She's a nurse practitioner in the NCCU. She's been with us since 2008 as a nurse practitioner and recently graduated from the University of Virginia with her PhD, and her area of research interest is in palliative care, particularly neuropalliative care. So it's my pleasure to introduce Lourdes, a friend and colleague.
Thank you. Thank you for that very kind introduction, Betsy. Well, it is a true honor and pleasure to be here with each of you today. I am, in Ski's words, I am completely in awe of the vision that everyone has had in this room to make this experience a truly collaborative experience in neurocritical care. And I thank everyone for all of their efforts in doing that. So we have come together today to celebrate the 40th anniversary of the Johns Hopkins Neuroscience Critical Care Unit. And since the first vision of the Neurosciences Critical Care Unit here at Johns Hopkins by our founding director, Dr. Daniel Hanley, to the cutting of the ribbon by our director of neuronursing, Shirley Sommer, Dr. Cecil Burrell, and our nurse leader, Judith Lauer, who we all know as Ski. Our specialty has blossomed over the past 40 years. As pioneers and innovators in the care of patients with life-threatening neurological and neurosurgical illness, we have been instrumental in the growth of our specialty. Neurocritical care has celebrated tremendous milestones and technological advances over the past 40 years that have improved and enhanced the care of our patients. Over the past 40 years, great strides have been made in the care in stroke care with the NINDS IV-TPA trial for ischemic stroke as only one of many examples. We have learned that surgical decompression reduces mortality and poor outcomes in patients with MCA stroke and malignant edema. Our knowledge of thrombectomy for stroke has grown and saved lives. And significant efforts have been made in large, randomized clinical trials to gain an understanding of our patients with intracerebral hemorrhage. And our targeted care of TBI patients has been enhanced with the advent of brain tissue oxygen monitoring. We have witnessed technological advances that have created targeted interventions for our patient populations. Technologies such as temperature management systems, cerebral blood flow measurements, multimodality monitoring, microdialysis, cortical EEG monitoring, and thrombectomy devices. And our goal of achieving precision medicine has led us to artificial intelligence and machine learning that will provide opportunities to improve the outcomes of our patients. And so while many significant milestones and technological advances have been achieved over the past 40 years, there are two questions that are perhaps the most salient questions in neurocritical care that remain a challenge for us to address. How can we predict a meaningful outcome for our patients? And how do we know whether to treat aggressively or to limit or withdraw life-sustaining treatment? So balancing our desire and the desire of our patients and families for accurate early prognostication with the difficult decision of whether to treat aggressively or to limit or withdraw life-sustaining treatment is perhaps one of the most prominent conundrums in neurocritical care today. And so our challenges in neuroprognostication have been highlighted in numerous statements, including from the Neurocritical Care Society. We have identified that while evidence-based guidelines for best practice have been impactful in many neurocritical illness states, an equally meaningful problem that remains to be addressed is determining when to apply the evidence-based guidelines and when to instead limit or withdraw life-sustaining treatment. So why is it so difficult for us to be able to predict the outcome of our patients? Well, when we compare the trajectories of illness in many disease states without limitations of life-supportive measures, such as sudden death, frailty, advanced cancer, organ failure, the onset of neurocritical illness, which is noted here in the upper right-hand corner, it is often occurs with a very sudden and precipitous decline, and our patients often do not do not proceed to death, but instead they display a slow and prolonged recovery and fail to demonstrate improvement, leading to severe and permanent disability, and in some cases, leading to a persistent vegetative state. Death, in many cases, is the result of the decision to withdraw life-sustaining treatment. About 13 to 15% of patients in US-based neurocritical care units have life-sustaining treatment withheld or withdrawn. Limitations in life-sustaining treatment precede approximately 61% of deaths in neurocritical care today. So understanding that death in our patient population is a result of the decision to withdraw life-sustaining treatment, we are limited in our ability to understand the natural history of many forms of acute neurological injury. And for survivors, we rarely have the opportunity to participate in their long-term care, follow-up, or recovery. Now, we have made attempts to predict outcome in our patient populations, but the literature has also highlighted the challenges with prediction models for various forms of acute neurological injury. So goals of care decisions center on prognostic estimates that are commonly derived from analytic models that are based on early predictors of poor outcome. They are inherently biased by the inclusion of populations in whom withdrawal of life-sustaining treatment is commonly performed. And they are imprecise to apply at the individual level. And they have failed to consider the long-term recovery trajectories of those allowed to survive. And so preconceived notions about futility of care may be relayed to surrogate decision makers in goals of care discussions prompting withdrawal of life-sustaining treatment, and utilizing perceived outcome in patient populations in whom withdrawal of life-sustaining treatment is performed may lead to self-fulfilling prophecies, which Dr. Kira Becker reported more than 2 decades ago. So it is critical that we address how we balance our challenges with neuroprognostication and decision-making for the greater good of our patients and their families. And so to support this with ICH data from CLEAR-3 and MISTY-3, we performed a retrospective comparison of patients who did not have withdrawal of life-sustaining treatment to patients who had withdrawal of life-sustaining treatment to estimate the influence of the commonly described disease severity predictors of poor outcome: age, GCS, ICH location, blood burden. And so for every year increase in age, there was a 4% increase in the odds of having withdrawal of life-sustaining treatment performed. And patients with a GCS of 9 to 12 were 2 times more likely to have withdrawal of life-sustaining treatment performed than patients with a GCS of 13 to 15. And patients with a GCS of 3 to 8 were 4 times more likely to have withdrawal of life-sustaining treatment performed. Patients with a total blood burden of greater than 55 millimeters were nearly 5 times more likely to have withdrawal of life-sustaining treatment performed. And so this establishes that the previously described early predictors of poor outcome that underpin the most commonly utilized prediction models in ICH are associated with withdrawal of life-sustaining treatment. So we also examined the ICH scores of patients who were enrolled in the MISTY-3 trial who had withdrawal of life-sustaining treatments and survivors who had similar baseline disease severity predictors as patients who had withdrawal of life-sustaining treatment. And I'll refer to that group as the matched survivor group. Now, the highest proportion of both groups, patients who had withdrawal of life-sustaining treatment and matched survivors, had ICH scores of 3, which is correlated with a predicted mortality of 73%. Now, for those who died as a result of a decision to withdraw life-sustaining treatment, the pattern of withdrawing life-sustaining treatment followed the prognostication of the ICH score. And for the matched survivors, they defied their odds of survival. And so in examining the self-reported health-related quality of life scores at 1 year of the survivors in MISTY-3, including all survivors, those survivors who were matched by disease severity to patients who had withdrawal of life-sustaining treatment, and matched survivors who were living at home, which accounted for nearly 73% of the matched survivor group, all survivor groups demonstrated median health-related quality of life scores that approached the U.S. population norm, with a higher percentage of matched survivors living at home having scores approaching the U.S. population norm for age-matched persons that had never experienced an intracerebral hemorrhage. And so for the matched survivors, those who had a predicted poor outcome, not only did they survive, but they had a favorable outcome in terms of quality of life 1 year following their injury. And so perhaps one of the most challenging questions for us to answer and to explore with our surrogate decision makers is, will my loved one have an acceptable quality of life? And so medical sociologists have explored this intersection between disability and quality of life. And in his 1986 address to the American Sociological Association, Saul Levine, who was a prominent medical sociologist who thrived on the sociological study of human behavior and the complexities of medical care delivery, discussed why quality of life has emerged as a major concern in healthcare in the 1980s. And there were 4 reasons that emerged. The first is the emergence of chronic conditions. The second is the tremendous burgeoning of new technology that prolonged the life of the dying. And significant questions arose from this. So to what extent should these innovations be applied? And what are the limitations of their use? And there was a concern for healthcare costs. How much cost and effort should be expended for patients who have lost the capacity for social interaction? So the advent of major social events also played a role in the emergence of quality of life as a major concern. Social events that critiqued our healthcare system and that were accompanied by a growing concern to humanize healthcare. And so Saul Levine wrote in his address, the concept of quality of life goes beyond the ideas of activities of daily living, important as it may be. The latter does not convey the social dimension as fully as does the notion of quality of life, which directs attention to the more complete social and psychological being. The individual's performance of social roles, their mental acuity, their emotional state, their sense of well-being, and their relationships with others. And so using the example of quality of life after stroke, Kreutzfeldt and colleagues described 3 potential trajectories of quality of life following stroke. Now, each of the trajectories begins with a baseline quality of life gap, where expectations and experience run parallel. Now, when the stroke occurs, experience falls below expectations, and that gap widens, adversely affecting quality of life. If the symptoms resolve, the gap may narrow again, implying a return to the patient's previous quality of life, as you can see here in Model A. Now, if no recovery occurs and the expectations do not change, the gap persists or widens, and in this case, the quality of life is worse than before. In Model C, after some time, the patient learns to accept the disability and recalibrates expectations, and the gap narrows. In this situation, the quality of life may eventually be no different in the patient who recovers from their stroke, as in Model A, and the patient who is left with permanent disability, as in Model B. Now, the arrow here in Model C suggests a change in experience, where experience may even exceed expectations, resulting in what has been coined as the disability paradox. Now, most current measures of predicted outcome refer only to the time period before this adaptation, when the illness has a predictive negative impact on the patient's quality of life. And so goals of care decisions are often made prior to the potential for adaptation. And so to make this decision, we ask surrogates to reflect on who the patient was before their illness, what they enjoyed, what they disliked, right? And this approach may have significant unintended consequences, because the surrogate is likely to remember a loved one who was healthier, more active, and less dependent. And so translating patient preferences into treatment choices is really based on predicting future quality of life, which, as we all know, is extremely challenging for us to be able to predict. And so the disability paradox has been largely described as a theoretical construct to date, sometimes observed in practice. We have all shared stories of patients that not only survived against all odds, but have thrived. And yet this paradoxical question has not received much attention in neurocritical illness states. Our metrics of success in therapeutic trials have focused primarily on survival and functional outcomes, such as the modified Rankin scale, just as one example. But we have failed to capture the more complete social and psychological well-being that is what defines personhood. And so, building upon the work of Saul Levine, sociologists have sought to answer this paradoxical question: why do so many people with serious disabilities report that they experience a good or excellent quality of life, when to most external observers, these individuals seem to live an undesirable daily existence? Well, we're learning that discrepancies between disability and survivor-reported well-being exists in many forms of acute neurological illness. In TBI, we have learned that up to 50% of patients with severe disability reported health-related quality of life scores within or above the satisfactory normative range. And among survivors of poor-grade subarachnoid hemorrhage, more than 80% reached a favorable outcome with health-related quality of life scores equating to a good quality of life. Only a minority of survivors reported a poor quality of life. And in ICH, our very own Dr. Vashank Shah and colleagues demonstrated that among survivors of severe intracerebral and intraventricular hemorrhage with initial poor functional outcome, more than 40% recovered to a good outcome by 1 year, with both good and functional outcome groups demonstrating improvement in self-reported health-related quality of life scores over time. And so, contrary to the idea that discrepancies are unusual, many patients with poor functional outcomes reported well-being that was at or above the boundary considered satisfactory. And so challenging the idea that satisfactory health-related quality of life in patients with disabilities should be described as paradoxical, and it questions the common views of what constitutes an unfavorable outcome for our patients. And so despite the frequency and paramount importance of these consequential decisions, very little research and resources are available to guide clinicians and surrogate decision makers in navigating our challenges inherent within the complex nature of goals of care decision making. Our prognostic challenges stem from the incomplete knowledge of the natural history of several forms of acute neurological injury, in part due to the role of withdrawal of life-sustaining treatment, insufficient health-related quality of life data in most cases of acute neurological injury, and a scarcity of data on the long-term recovery trajectories of survivors of acute neurological injury. Now, these obstacles impact our ability to assist decision makers in making high-quality goals of care decisions, one that is truly aligned with the patient's preferences and values. And so, how do we achieve the pinnacle of precision medicine in neurocritical care? How do we answer the most challenging of questions? How are our patients going to do? How do we know what to do for them? And how will we help people make difficult decisions that could be life-changing or life-ending? Well, neuropalliative care is both a philosophy and an organized, highly structured approach to providing quality of life-oriented care to patients with serious illness and their families. Now, before I move on, I want to highlight two very common misconceptions in palliative care. The first is that palliative care, it is not just for the dying. Palliative care aims at improving the quality of life of patients and their families throughout all stages of illness, from the acute phase to recovery phase to the end of life. And the second misconception is that the use of the term palliative care is often equated with palliative care consultants or specialists, and these are highly skilled individuals, and they're knowledgeable about serious illness communication and tend to work in an effective, collaborative, multidisciplinary team. But as neurocritical care clinicians, we all provide palliation to our patients and families. We lead discussions surrounding goals of care decisions in which we elicit patient preferences and values to make informed, shared decisions. Palliative care should be considered an approach to patient care by any clinician, as a set of skills for clinicians to learn and as a goal to ensure optimal quality of life at all stages of illness, and to achieve high-quality communication and decisions for those affected by acute neurological injury. And so how do we focus our efforts toward the shared center of our stakeholders, neurocritical care clinicians, neurologists, neurosurgeons, our patients, and their surrogate decision makers, in order to optimize the intersection of neuropalliative care and neurocritical care? There are 4 goals. The first is to upskill clinicians in primary palliative care to provide quality of life-oriented care and communication. The second is to normalize prognostic uncertainty in our practice and in goals of care discussions. The third is to implement decision support mechanisms that align patient preferences and values with treatment options while accounting for the dynamic adaptations and coping that we see with various different disability states. And the last is to optimize health-related quality of life throughout all phases of acute neurological injury. And so what does the integration of a neuropalliative approach in neurocritical care look like for the way that we will educate our neurocritical care clinicians, the way that we will practice neurocritical care, and the way that we will approach research in neurocritical care over the next 40 years? Well, as neurocritical care clinicians, we are all trained to perform life-saving interventions, yet we are not formally skilled in how we approach serious conversations with our patients and their surrogate decision makers. We have an opportunity to improve our primary palliative care skills by using programmatic approaches such as Vital Talk for clinicians, for nurses, advanced practice providers, residents, and fellows that will provide us with a formalized approach to effectively navigate goals of care conversations in the setting of prognostic uncertainty, provide care that aligns with patient preferences and values while acknowledging that outcomes are challenging to predict, and create a clinical practice and research paradigm shift that emphasizes health-related quality of life. As a specialty, we can engage with accrediting bodies to make palliation training a programmatic requirement for neurocritical care clinicians. And so understanding that measures of good outcome have commonly been defined by functional disability primarily in our research, we need to better understand the narrative of those with the lived experience of acute neurological injury and their carers. We need to understand what constitutes a meaningful recovery, what it takes to achieve a meaningful recovery, and what physical and psychological challenges have been endured along the path from critical illness to optimal well-being. And so partnering with our stakeholders, survivors, caregivers, experienced surrogate decision makers, those who have gone through the process of making a difficult goals of care decision, neurocritical care clinicians, neurologists, neurosurgeons, palliative care, and researchers, perhaps through a think tank approach, it will allow us to understand what metrics define optimal well-being for us to be able to align our educational goals, our clinical practice outcomes, and our research aims within the context as what is most meaningful to those with the lived experience. And so critical care societies, including the Neurocritical Care Society, have called for an urgent need to develop and implement decision support mechanisms that minimize psychological morbidity that affects so many of our surrogate decision makers as a result of the process of making a highly consequential decision on the behalf of their loved one. Now, to date, mechanisms of providing decisional support to surrogates are really lacking in neurocritical care. And so how can we approach decisional science using a palliative approach? Well, there is literature supporting the development and implementation of decision aids in other critical illness states, but few have been developed to support the decision makers of patients with acute neurological injury. Now, decision aids are evidence-based tools that supplement rather than replace family clinician communication. Now, they differ from usual health education by emphasizing the decision being considered and personalizing the care options and outcomes for the purpose of preparing people to make high-quality, informed, shared decisions. Now, they assist with the recognition of the preference-sensitive nature of the decision and offer formal guidance for communicating preferences and values during the decision-making process. And so the understanding that decision aids are powerful tools, they must be underpinned by a theoretical model that allows for the application of prognostic uncertainty rather than the prediction models that we have become accustomed to until we are ultimately able to precisely and accurately incorporate the long-term recovery trajectories of our patients and their families. And so thinking outside of our usual realm, perhaps a social network in which inexperienced decision makers, those actively going through the process of a goals of care decision, are connected with experienced decision makers so that they can have an exchange of narrative that could better prepare people for the process of making this highly consequential, difficult decision. And so to bridge the gap between acute care and recovery care, should we consider building mechanisms of neurocritical care clinicians to follow survivors over time so that we can understand the long-term recovery trajectory of our survivors, to understand the perspective of those who care for them, and to understand the benefits, obstacles, and challenges of neurorehabilitation and reintegration into society, as Dr. Hanley mentioned earlier during his talk. So while it is understood that typically follow-up care follows within the domain of our neurosurgical and neurology colleagues, perhaps our approach will focus on providing a means of longitudinal care from critical care to recovery. And so our research agenda for the next 40 years should direct our efforts on what we gain from our stakeholder partnerships. What means the most to our patients and families? And as we learn and grow from our neuropalliative approach to care, we need to examine the impact of current prognostication on the deliberation process and goals of care decision-making. We need long-term recovery data from survivors, particularly self-reported health-related quality of life, to support decision-making and clinical trial and research intervention endpoints. We need to understand survivor adaptation and coping to disability and the impact on perceived health-related quality of life. And we need an emphasis on decisional science to evaluate decision support mechanisms that incorporate survivor-reported and surrogate outcomes data. And as we refine and enhance our neuropalliative approach, we need to measure our impact on patient and surrogate outcomes as defined by our stakeholders. So our research agenda over the next 40 years must meaningfully engage with our patients and our families. So we have come so far over the past 40 years since the first vision of a neurosciences critical care unit here at Johns Hopkins, where we saw the need for an interdisciplinary approach to care with neurologists, neurosurgeons, anesthesiologists, and specialty trained nurses, all aligning efforts to improve the care of our patients with acute neurological injury. In 2062, our approach will allow us to break boundaries and to create paradigm shifts in education, research, and practice that emphasize human flourishing and the optimization of well-being for our patients and their families. And so over the next 40 years, our collective efforts should focus on creating frameworks and approaches to neuroprognostication and goals of care decision-making that achieve the pinnacle of precision medicine. And that is to encompass what is most meaningful to our patients and our families in research, clinical practice, and education. Thank you.